Oh, you want this?
Good afternoon, everyone. Well, is my microphone working? Yes, perfect. It's a real pleasure and honor to be here, and I've seen a few familiar faces and many new ones. And you might start yourself off by saying, why on earth have we got a neurosurgeon talking at the Institute of Mental Health? And I think this is a good example of why we need to bring professions together so we know what each other are doing. And when people think of neurosurgery, they think about taking lumps out of people's heads and blood clots out of people's heads and sorting trauma out. And this is what I've had the pleasure of treating over the years. But also, neurosurgeons treat disorders that affect the circuitry of the brain, the function of the brain, where the brain looks structurally normal but isn't working normally, such as Parkinson's disease. Do an MRI, it looks fairly standard. Dystonia, essential tremor, and even depression, and OCD, and maybe anorexia. And I'm going to talk you through a bit of the evidence and the ethics about this. Now, the story of functional neurosurgery really starts with movement disorders. And surgery for movement disorders was born of desperation. And Victor Horsley, the world's first surgeon, just down the road at Queen Square, was taking out the motor cortex of patients to relieve their consistent tremor or athetosis and painful movements. These were desperate times. And patients were grateful to be paralyzed after these operations. And Horsley put together all of this work that was succeeded by generations of neurosurgeons, but of course this is archaic. We no longer do this anymore. And functional neurosurgery has moved on for movement disorders and is a real success story. And the reason for this is really teamwork. And teamwork between neurologists and neurosurgeons who are based in the same hospital. And because of history, psychiatrists have often been segregated away from neurosurgeons, so we even haven't had the chance to collaborate as much as we should, and that needs to be put to right. Moreover, the stereotactic technique, which is a way of delivering safe, accurate, and effective surgery deep within the brain, right, was developed. And we have performed over 1,000 stereotactic operations since 2002 without a single death, without a single stroke. So safety is very important. We also have this wonderful tool called MRI, which gives us structural vision of the brain as well as connectivity maps of the brain that we can use in planning. And we can perform stereotactic lesions, tiny lesions the size of your little fingernail, but well placed to ablate tremor, for example, or deep brain stimulation, a technology that allows us to put a neural pacemaker under the skin and connect it with wires that are precisely targeted to very precise parts of the brain to modulate the circuitry to help with neurological conditions. And because we can change the stimulation parameters, we can titrate the efficacy and side effects. So what we have here is a patient with Parkinson's disease. She isn't tolerant of medications because she's got young onset PD. She vomits when you give her dopamine. And you can see the cardinal symptoms, the stiffness, the tremor, the bradykinesia, the slowness of movement, the akinesia, the slowness of movement. You can see we can perform surgery under local anesthetic, right? It's even better than going to the dentist. Our patients prefer us to the dentist. And when we put the electrode in the right spot, we can turn the stimulation on. And as we turn the stimulation up, you can see that our neurologist is in theatre with us, and the rigidity goes away, the tremor goes away, the bradykinesia goes away. And most of the motor symptoms are markedly better. And this is why I went into functional neurosurgery, because this was nothing short of magic for me, but it isn't, it's science. Now, the history of neurosurgery for mental health disorders was also born of desperation. And we all have heard of these frontal lobotomies, these dreadful procedures where we were ablating the frontal lobes or disconnecting the frontal lobes, often by psychiatrists. Freeman was a psychiatrist, never qualified as a surgeon, right? But these were desperate times. And times have moved on. And I'm familiar that many psychiatrists and psychologists don't want to consider neurosurgery because of this terrible past. But times have moved on. The ethics of this was discussed back in the 1950s, let alone now. And the BMJ said, well, churchmen have taken part in debates in lay journals saying that the soul is damaged by leucotomy. And slightly tongue-in-cheek, the editor said, well, if the soul can survive death, surely it can survive a leucotomy. Right? Now, surgery for psychiatric disorders died, rightly so, when you're doing lobotomies, because we had medications that could help these patients in the 50s, chlorpromazine, etc. but also there's a backlash from the public telling us we shouldn't be doing this, and that's quite right. We shouldn't have been doing that, but those were desperate times. Times have changed. So where are we now? We are now in a position that there are certain diseases that cause problems, disorders of neural networks, neural circuits. And we know that that's true of Parkinson's, tremor, dystonia, but also Tourette's syndrome, OCD, major depressive disorder, and anorexia. And this is a paper from 1996, where cognitive behavioral therapy restored blood flow abnormalities in patients with severe OCD. In other words, there are abnormalities within the network in OCD, and just by doing cognitive behavioral therapy, you can improve those functional abnormalities deep within the brain. Because environment affects the brain, but sometimes cognitive behavioral therapy is not enough, and we have to do something to the brain for cognitive behavioral therapy to work. So what's the evidence here, okay? So there has been a move, because there have been over 150,000 patients who have had deep brain stimulation for movement disorders, successfully and safely, there's been this move to move from neurology to psychiatry. And in fact, this is an artificial distinction, because psychiatrists are just clever neurologists. They're dealing with higher disorders of the brain. And many diseases, like Parkinson's disease, are neuropsychiatric disorders. So neurologists have to be psychiatrists as well to help their patients. And there's lots of class 1 evidence showing that we can help mental health disorders with functional neurosurgery. Tourette's syndrome, lesioning for OCD, subthalamic nuclear stimulation for OCD, stimulation of the ventral capsule. This is class 1 evidence where you switch the device on and off without the patient's knowing and look at the efficacy, measuring on and off without the patient, without the psychiatrist knowing the state. So I just want to talk to you very briefly about our role, Queen Square, in providing that evidence base. So Tourette's syndrome is a disease or a condition that straddles neurology and psychiatry. You all know about the involuntary tics, coprolalia that's present in a percentage of patients. And the first case report was published of deep brain stimulation was published in 1999. And when we saw that this was promising, first we did a small open label series at Queen Square together with a neuropsychiatrist, Professor Eileen Joyce. And when we had determined that there was promise in this technique, we designed a randomized controlled trial of parallel deep brain stimulation for Tourette. And in the blinded phase, there was a significant improvement in tics on the Yale Global Tic Score. And when you leave the stimulation on for longer, that improvement gets better. And that's the same patient here. And I'll let him tell his own story.
And after you adjusted the left-hand side, I think it was, I had a horrible sort of panicky sort of fight or flight adrenaline feeling for a couple of weeks. And as that started to fade off, the tics went with it, and since then I've actually been getting calmer and calmer. This is the calmest I've been in my memory, basically. First and foremost, I've actually been able to hold my daughter. That's been nice. I've been able to sleep in the same bed as my wife without actually having to sleep on the sofa every night. I'm not hurting myself every day. I can finish the sentence without swearing or whistling. That's always nice.
This is not a placebo. When their battery runs out, the tics come back, and we have to change the battery prophylactically because they hate being reminded of the condition they suffer from. So moving on to obsessive-compulsive disorder, Bart Natan was the first person to perform deep brain stimulation in 1999. And by the time we had come in on the action, there was already a randomized controlled trial of deep brain stimulation at 2 different targets in the brain, called the ventral capsule and the subthalamic nucleus. And when we designed the trial some years back, we said we want to examine these 2 sites within the brain and compare them against each other. So we did a randomized controlled trial in very few patients, just 6 patients, but these were the worst of the worst OCD patients through the UK, right? They had already had more than 2 SSRI trials for more than 12 weeks. They had trials of CBT, including inpatient care, more than 32 on the Y-box scale. That's extreme OCD. To give you an idea, one of the patients wouldn't drink, because if she drank, she'd have to pee, and after she peed, it'd take her an 8-hour ritual to clean herself. That's the level of severity we're talking about. And when we compared the 2 sites of stimulation in a blinded fashion, what we found that OCD symptoms improved whichever target you used, significantly so. But when we looked at fairly detailed neuropsychological tests, we found that one target significantly improved mood, but the other target significantly improved cognitive rigidity, the ability to change your mind about a certain set of facts. So what we found here is that we actually affect different networks with different nodes, both of them improving OCD, but one of them improving mood and the other improving cognitive flexibility. And this isn't just a score that has no relevance to the patients. These patients went from a baseline of 22 on the Global Assessment of Function scale, that's inability to function in many areas, to a scale of 72 after CBT. Because what we found is that if you give cognitive behavioral therapy after DBS, these patients didn't respond before, but now they're able to engage with cognitive behavioral therapy and have additional improvements. So this is by no means saying neurosurgeons want to come here and take your jobs away from you, right? This is a collaborative effort. It's not just about deep brain stimulation. I find this very troubling. No one has any problem with me resecting the temporal lobe for someone with severe refractory epilepsy. But then everybody starts talking ethics to me if I do a capsulotomy. Look at the size of the lesions of a capsulotomy compared to a temporal lobectomy for OCD. Why is it that we have such discrimination against mental health patients? If we know there's class 1 evidence for this type of operation to improve the quality of life of patients with OCD, why do we give a good quality of life to epileptic patients, but not to mental health patients? And we've looked at this study, we've looked at deep brain stimulation versus a lesion of the same site within the brain, and what we found that more patients had a response with lesioning, and more patients went into remission with lesioning. So lesioning is not to be sniffed at. This is my penultimate slide, Alan. Deep brain stimulation for major depression. This has had a lot of press, and Helen Mayberg and Andres Lozano in Canada looked at CG25 because functional images showed an overactivity of this part of the brain in depressed patients. But when you look at the trial results, there was absolutely no difference between control and sham. Therefore, deep brain stimulation in this area of the brain does not work. Okay? However, we provide a national ablation service together with the Advanced Intervention Service in Dundee and UCL at Queen Square, and we can perform cingulotomies and capsulotomies. Again, very safe procedures, but when we looked at the results of the long-term capsulotomy from refractory depression, if you look at the long-term results of this study, there was 18% in remission. If you look at long-term results after capsulotomy, you've got 40% in remission. Therefore, this may be the sham of what surgery does, but we have to explain the additional benefit from a capsulotomy. And this is an area rife for research. So please, let's work together to help these patients and to help patients with depression. So in summary, functional neurosurgery is safe. It's effective. We have class 1 evidence in Tourette syndrome and OCD. There's a great opportunity for ethical research in this field. And I'm particularly interested in anorexia, of which half of patients have a form of OCB. Patient selection is totally critical to good outcome, and therefore this needs to be a multidisciplinary effort between surgeons and psychiatrists and psychologists. Unfortunately, there are very few psychiatrists interested in neurosurgery, and I hope that this event, and hopefully more like them, will change that. I challenge you, is it unethical to consider neurosurgery for patients with refractory mental disorders? Or is it unethical not to refer patients for neurosurgery when there's class 1 evidence of efficacy and safety? And I really hope that this new Institute of Mental Health will bring us together. So this is the group of people I work with. It's a lot of fun working at Queen Square. This is the OCD network, which is a national network. And this wasn't my work, this is the work of all these people here. So thank you very much for your time.
Great. Provocative, really exciting. And questions to the audience. I guess only a neurosurgeon would call psychiatrists clever neurologists, and thus...
Thought you'd like that one, Alan.
Thus upset everybody at the same time. Anyway, comments or questions from anybody? Everyone's sort of stunned. Here we are. Sorry. Yes. I think we have a microphone.
Hi, I'm Stephen Ginn. I'm a psychiatrist from CNI. If you, just an ethical question, I'd be interested to know what you think. If you had a patient that you gave DBS for OCD, it didn't improve the OCD, but it made them feel, so they say, it made them feel happier. Would that be an issue?
So the reason we do surgery is to help the patients. So if the patients feel better, then I don't think that's a negative thing. There's a lot to learn from every single patient who undergoes surgery, so there's the research aspect of it. Our experience in the field is not vast, but the thing that improves most with these sort of operations is the OCD.
Just to follow up, the reason I ask is just that I went to a talk by a neurosurgeon who said they switched it off under those circumstances.
Yep.
Okay. We have one more question right at the very, very, very far end of the room, just to test the
Running skills.
whatever you test, sort of manoeuvre.
It's a walking test.
Thank you, Ludvic. That was very refreshing. Hi. One of the reasons why we have normal treatment resilient and resistant mental health is because there's comorbidity. So sometimes with comorbidity, there may be two parts of the brain that are showing overactivity, or one's overactive and one's underactive, and vice versa. Are you looking at ways to do that, or do you think that's too dodgy to kind of go into those areas?
Too dodgy. I don't think surgeons ever think things are too dodgy.
I think we're early in the field. We have some randomized control trials showing good efficacy with single disorders. I personally think we need to consolidate that and understand what we're doing and what the side effects are and what the long-term effects are, which at the moment are very promising. So patient selection is really important. But to give you an example, when we started doing surgery for Parkinson's disease, depression was an absolute contraindication. We were doing it for the motor symptoms of PD. Nowadays, because we have experience with a large number of PD patients, depression is not an absolute contraindication. In fact, what we find is that when we've treated the motor symptoms effectively, very often the depression improves concomitant with it.